You have to show the main screen, Mr.
Cell transplantation. I will show to you some slides. First of all, I would like to thank the ISBMT, the Indian Society for Blood and Marrow Transplantation, for the collaboration to perform this webinar, and also to the MICE Ideas team that provided the technical support generously that made this webinar possible. My name is Sebastián Galeano. I am secretary of the WBMT, and I am the past co-chair of the Education and Dissemination Committee. I welcome Damiano Rondelli, Adriana Sever, and Yoshihisa Kodera, the new co-chairs of this committee. The WBMT is a federation of the different transplant organizations around the world, organizations that are involved in different aspects of stem cell transplants, such as donor issues, transplant registries, accreditation organizations, and all the transplant societies that you can find in the different regions, the Asia Pacific, the African region, the Eastern Mediterranean, Europe, North America, and Latin America. The WBMT is a non-governmental organization that it is in official relations with the WHO. I invite you to visit the WBMT webpage where you can find more information and also the recorded versions of the past webinars. One of the responsibilities of the WBMT is to collect data on the transplants that are performed around the world. And as you can see here, there is a constant increase during the last years in the number of transplants performed worldwide, a little bit more autologous than allogeneic, but now we are performing more than 100,000 transplants per year in the globe. It is also important to mention that the transplant rates, the number of transplants per 10 million inhabitants per year, that talks about the accessibility of the transplant for the population in the different regions, is very heterogeneous, with the highest transplant rate in North America and Europe. But what I would like to mention is that those regions with lower transplant rates, here is Latin America, Eastern Mediterranean, Africa, and Asia Pacific, are the regions that are increasing, the speed of increase is higher. So it is expected that in the near future, this gap, at least, it will start to decrease. And what about if we check the numbers of allogeneic transplant? You know, autologous is a little bit higher than allogeneic, but there are significant changes, particularly in the donor source for allogeneic transplants. You can see here in light blue is unrelated donors that are increasing, and in green, you can imagine it is haploidentical transplant that are increasing very fast, in particular in lower and middle income countries. And why is this data so relevant for what we are discussing today, viral diseases? Because we are going to face more and more of these problems in the near future. Number one, there is an increasing number of transplants. Number two, we have transplant with a higher degree of immune suppression, like unrelated and haploidenticals, that will predict that we will have more and more viral reactivations in the near future. And of course, more transplants are done in lower and middle income countries where the incidence of reemergent viral diseases is higher. So we need to learn a lot about this. And I thank our distinguished speakers, Simone Cesaro, Clarice Machado, and Genoveva Papanikolaou for being with us today. I would also like to thank especially Alok that said yes when I told him to do this webinar. Alok is a professor of medicine at the Department of Hematology and a head of the Stem Cell Transplant Center at the Christian Medical College in Vellore, India. He will introduce the first speaker.
Alok, thank you, Sebastian. I hope you can hear me. It's indeed a great pleasure to be part of this program, and the Indian Society of Blood and Marrow Transplant consider it's a privilege to partner with the WBMT to help support this webinar. And with that, good afternoon, good evening, good morning, depending on which part of the world you are in today, to this webinar. As Sebastian mentioned, it's indeed our privilege to have three distinguished speakers to talk to about CMV infections in transplant, which has been a major issue and is continues to be a major issue in transplantation all over the world. So with that, I'd like to introduce the first speaker, if we can have the slide, Dr. Simone Cesaro. He's from the Ospedale Donna Bambino in Verona, Italy. He has a lot of experience in transplantation and treatment of these viral infections, and he will talk to us about BK virus and Epstein virus infection in transplantation. Simone, thank you for being with us today. The floor is yours.
First of all, I would like to thank the organizer for this invitation to this interesting webinar. My job today is to talk about BK and EBV infection. BK virus was isolated, first of all, for the first time in 1971 in ureteral cells of a patient BK by electron microscopy. It belongs to the polyomavirus hominis family, and this infection is usually asymptomatic, subclinic during the first part of the life in the infancy, but in immunocompromised host, this virus can give important complications such as the graft rejection, kidney transplant, and hemorrhagic cystitis stem cell transplant. The virus enters the body through respiratory tract or gastrointestinal tract. The virus has a multiplication and produces primary viremia, lymphocyte, and monocyte, but after that, the virus has a multiplication in the epithelial cells of ureter and of the bladder, and it stays there for all the life. So in latent version, as a latent infection for all the life, and may undergo to occasional reactivation. In fact, 5% of adult population can have an asymptomatic excretion of BK virus, polyomavirus in some part of the life, such as in the elderly or during the pregnancy in particular. But in immunocompromised host, BK virus can replicate, give infection with a high viral load, and determines also disease with cytopathic modification of the cells, death of the cells, and the viral shedding. In the end, the most frequent organ damage is interstitial nephritis and hemorrhagic cystitis. You can see here in the picture the coil cells, that is cells from ureteral and from renal organ that has been infected by the virus, and you can see here in the cytologic examination with the urines, and at the microscopy you can see in the nucleus that this is packed with a lot of virus of the virus. From the point of severity, we can grade the hemorrhagic cystitis in 4 grades, but they are very interesting for the clinician. The grade 2, that is when there is a macroscopic hematuria. Grade 3, when there is a macrohematuria with clots. And grade 4, when there is an impairment of renal function, particularly urinary obstruction by clots or renal insufficiency. To diagnose BK virus hemorrhagic cystitis associated with hemorrhagic cystitis, it is important to have the triad of symptomatic cystitis with the clinical symptom of dysuria, urgency, pain, urinary burning or discomfort, and the presence of a macrohematuria of grade 2 or more, and the presence of BK viruria with 7 logs or more copies per ml of urine, with or without BK viremia. Usually viremia is between 1 and 3 logs copies per ml of blood. And also it is important to exclude other causes of hemorrhagic cystitis by urine culture and instrumental examination. To have hemorrhagic cystitis, is important to have a BK virus infection in the post phase of a transplant, in the early phase of post-transplant period, but it is also important to have other factors that has an important role, because sometimes you can have BK virus viruria or viremia without any symptoms. But when there are other adjunctive factors, then hemorrhagic cystitis may develop. These important clinical risk factors are the presence or not of acute GVHD, in particular grade 2 for 4, the presence of ATG, the fact that the patient has received a transplant from an unrelated donor or from an HLA mismatched donor, or the fact that the transplant has been performed with the peripheral blood stem cells or cord blood stem cells. Another important risk factor is the myeloablative conditioning regimen, or the fact that the patient received the second or more transplant in the history. For the young patient, in particular for children, the age less than 7 years is a risk factor for developing hemorrhagic cystitis. Also, concurrent other infections such as that of cytomegalovirus or HHV6 can be a risk factor for that prone the patient to development of hemorrhagic cystitis. How to manage the hemorrhagic cystitis? Unfortunately, today we have only supportive care, and also we can act modifying the immunosuppression. So the main measure to manage hemorrhagic cystitis is to maintain a higher threshold for platelet transfusion, at least more than 30,000. At least this is in my clinical experience, in my clinical practice, perform blood irrigation to dilute the blood in the urine and to avoid the clotting formation, and to control pain and spasm by drugs, morphine, oxybutynin, or midazolam, and if possible reduce immunosuppression or change immunosuppression, try to find a regimen with sparing steroids. There are not recommended the use of tranexamic acid, that is a procoagulant drug that can be used sometimes in other types of bleeding, but not in hemorrhagic cystitis, because there is the risk that the clots can be developed with this drug in the bladder, and also no role for administration of polyvalent immunoglobulins. It is a very debated the use or not of fluoroquinolones. So we know that in vitro, fluoroquinolones have a capacity to inhibit BK virus replication, and the concentration, for example, of 120 microgram per ml, levofloxacin reduces BK viruria load by 90%. We know that with a dose of 500 milligrams ciprofloxacin, we can achieve this concentration capable to inhibit the BK replication in the urine, but ciprofloxacin is not achieving that efficient concentration in the plasma. And also the activity in the urine of fluoroquinolones, it depends by pH and also by the presence of cations such as magnesium. In the end, the fluoroquinolones seems not to be effective in preventing BK virus hemorrhagic cystitis, BK viremia, and also BK virus associated nephritis. This is the result of a meta-analysis considering 3 studies in more than 200 stem cell transplanted patients and 11 studies in almost 2,000 kidney transplant patients. Fluoroquinolones can reduce BK viruria, but also can be a risk in general for the infection, because they promote the resistance of bacteria in the urine. So they can promote the occurrence of multi-drug resistance infection. Other treatment that we can use for hemorrhagic cystitis are antivirals, in particular cidofovir, that can be given intravenously or orally, or sometimes intravesical to spare the nephrotoxicity of this drug. There are also experiences limited to some centers that have shown that hyperbaric oxygen therapy can accelerate, can speed the regeneration of the mucosa damage of the blood and mucosal damage, so it can be useful in this context, as well as the application of fibrin glue or platelet by cystoscopy directly on the surface, bleeding surface of the bladder. There are also some short report cases series about the positive effect of leflunomide, immunosuppressive drug that has an antiviral effect of vidarabine, but there are very, very few data. About cidofovir, the problem is that this drug has not a precise schedule. There are people, there are reports using this drug at 3 to 5 milligram kilo every 1-2 weeks, associated with the probenecid to spare from kidney toxicity, or other reports using cidofovir itself, 1.25 to 1.5 milligram kilo 1-2 times a week without probenecid. Certainly, cidofovir can have a favorable effect on complete remission. 68% of complete remission have been associated with the use of cidofovir, and can contribute to clearance of BK viremia in 91% of the cases, with a minor effect on BK viruria clearance. It has been observed in 20-32%. Usually, the administration of cidofovir is associated to reduction of at least 1 log of BK viruria in 47% of the cases. But the drugs we have to take in our mind that there are this drug has not a controlled prospective study, so the data are not so certain. The dose in the schedule is not well defined, and it also has a quite toxic profile with nausea, cytopenia, and renal failure up to 9% of the cases. To overcome the cidofovir nephrotoxicity, some report have reported the use of cidofovir intravesically. It is possible. The toxicity is limited to bladder with spasm or pain, but also, again, we have very little experience. Brincidofovir it is a lipid conjugate of cidofovir, and it was a pharma that gave much enthusiasm and potential use on hemorrhagic cystitis, but because this lipid conjugate has no renal toxicity and can achieve a higher plasma level than cidofovir, and so can inhibit more effectively BK virus replication in the blood. But this drug has never been marketed with this indication, and also has some gastrointestinal toxicity. This is an Italian report, a single center report about the efficacy of fibrin glue application by cystoscopy that has been used in 35 patients. 29 patients have had a clinical neurological response, and a sustained clinical neurological response was observed in 22 patients. Most of the patients received just one fibrin glue application by cystoscopy. 70% received 2 or 3 applications. This is a picture that shows how the fibrin glue application is performed. Cystoscopy, you see directly by cystoscopy the bleeding area, and you then spray directly the fibrin glue on this bleeding area, obtaining the coagulation and the stop of the bleeding. Finally, it is very important to underline that the recovery from hemorrhagic cystitis and the decline of the BK viruria has been clearly associated with immune recovery in terms of BK virus specific CD4 T cell and CD8 T cell. And on the basis of this fact, there are several studies that have shown that the use of CTL specific for BK virus can give a rapid response in patients with hemorrhagic cystitis. This, for example, is a a proof of a principle study, 60 patients that received 14 with hemorrhagic cystitis grade 2 or 3, 2 with nephritis, and all patients received a clinical benefit, and the use of a CTL, specific CTL for BK virus, determining a decrease of 85% by week 6 of BK viruria and 96% of BK viruria by week 9. And the gross hematuria resolved in 13 of 14 patients. The clinical result was associated with an improvement of CTL specific for BK virus. So the final conclusion for this type of infection, unfortunately, we have to say no major advance. We have training with the use of drugs for this complication. There is moderate evidence for side-effects. We have no prospective studies, so the quality of the data is not so robust. Supporting measures are still the first-line therapy, the most important first-line therapy, and the improvement has been reported by single-center experience by inducing regeneration of damaged mucosa by hyperbaric oxygen therapy, or by direct application with cystoscopy or platelet-rich plasma or fibrin group preparation. The future could be the possibility to use a BK virus or BV-CTS. These are promising, but we need more data, and also we need to see if it is possible to use this technique, this innovation on a broader scale, because there are problems for the costs and for the availability of this preparation. Moving to ABV infection, we know that it is an herpes virus 2, is a herpes 4. This virus is well known. Its transmission is by saliva mainly. The virus can enter the B cells of human B cells by CD21 receptor, CD35, or by cellular beta-1 integrase in epithelial cells, and is responsible of infection in children and adolescents. Most of these infections are subclinic, but in adolescents, particularly adolescent and young adults, at least 50% are clinically symptomatic as infectious mononucleosis. 90% of adults are BV seropositive late in the life, so the contact with this virus is very common. Unfortunately, this virus may undergo reactivation in immunocompromised patients. The diagnosis of ABV lymphoproliferative disease associated is made by determination of ABV anemia in the blood, by blood, plasma, or serum, and by instrumental examination, in particular CT scan or PET CT scan. That is important to stage the disease, to see the grade of involvement of the body, identify the lesion that can be most appropriate for the biopsy, and to document also the extension of the disease, and also to assess the response to therapy. It is more important, very important to underline that the biopsy is very crucial for the diagnosis of a proven PTLD, because it is not sufficient just to have a clinical symptom plus an ABV anemia documented in the blood. It is not sufficient to have for a diagnosis of a PTLD proven. The ABV infection is a very frequent in stem cell transplantation. We can document ABV infection by determining by PCR the ABV anemia load, and this situation can be vary according to the type of the transplant and the type of depletion, T-cell depletion that the transplant utilized. So the frequency of EBV infection can go from 1 3% up to 50-60%. But not all these patients that have EBV infection has also PTLD. In effect, in this large casuistic, you can see that the PTLD, proven probable PTLD, has an incidence of 1% in matched family donor transplant, but can goes up to 3% in unrelated donor transplant or mismatched family donor haplotransplant, up to 11% in mismatched unrelated donor transplant. So it's very important to see the entity of immunodepression this patient needs when perform the transplant. This is the most important point that correlates with the risk of PTLD. In fact, the major factor influencing the development of EBV PTLD are the T cell depletion, EBV mismatch serology between donor and the recipient, in particular when the donor is positive, recipient is negative, the risk is higher. The use of cord blood graft, the grade of HLA mismatch between recipient and donor. In particular, the risk is higher when this mismatch is more than one allele. And the presence of acute or chronic GVHD, a very high viral load or increasing EBV viral load, and the use of a reduced intensive conditioning regimen, the concurrent presence of a CMV infection in patients that have been splenectomized. How to manage EBV infection? In this last decade, an important and key role has rituximab, because rituximab can be used as a prevention to perform B cell depletion in vivo in patients that are receiving ATG in the conditioning regimen or have a partial T depletion, alpha beta T depletion. So rituximab can perform a B cell depletion and preventing so in this way the development of PTLD. B depletion can be also performed ex vivo on the graft by graft manipulation. These are the most important way to prevent PTLD in transplanted patient. Another important way to prevent PTLD is to monitor EBV anemia during the first phase, the first months of a transplant, at least in the first 3-4 months, and act when the anemia is increasing. We can act in several ways. In particular, we can administer rituximab post-graft infusions when the infection, EBV infection, is still asymptomatic, but the viral load is increasing. Or we can also, if they are available, give CTS. In this situation, when the patient develop a PTLD, a clear clinical evident PTLD, proven PTLD, the possibility to intervene are the use of rituximab associated with the chemotherapy or with CTS, specific CTS. It is very important also to underline that the risk of the PTLD can be modulated, can be reduced if you can reduce immunosuppression when the viral load is increasing. Not always it's possible, but it's possible, can be an effective measure. This is my scheme to monitor EBV during the transplant, the first months of a transplant. The EBV PCR is performed weekly, at least weekly, until day plus 100, 120, and after that date, only if clinically needed. If I have more than 1,000 copy on PCR, I confirm this data, but reduce at first immunosuppression almost immediately. And if the viral load is increasing to 5,000 or more, I act adding rituximab. So the final remarks for EBV infection is the EBV anemia monitor is fundamental for early intervention, and the reduction of immunosuppression is often feasible in this patient, and also is affecting the early stage of EBV infection. But if immunosuppression is not effective, rituximab has a very key role in terms of prevention, preemptive therapy, and also therapy. So it's very important to strictly monitoring the patient to choose the right time to introduce rituximab. The future could be EBV CTS, in particular third-party EBV CTS that can be ready available in the patient that who need on immunotherapy. But so far, this therapy is limited to few centers, and we have to see if immunotherapy will be in the future applicable on large scale, also to all transplant centers, depending on the availability and the cost. Thanks for your attention.
Thanks for this wonderful talk. And then we will move to our next speaker. I remind you that you have a Q&A box that you can type your questions, and we will, with Alok, will summarize with me, and then we will ask the speakers about the questions that you write in the chat box. So our next speaker is Clarice Machado. Clarice is the head of the virology department at the Institute of Tropical Medicine in Sao Paulo. And she's also the infectious disease specialist working at the Amaral Carvalho and Albert Einstein hospitals in Sao Paulo, Brazil. Clarice also has developed the Brazilian guidelines that we use in other countries in Latin America. So thanks, Clarice. Let's go to your lecture.
I'd like to thank the invitation to participate in this webinar and the opportunity to share our experience in re-emerging viral diseases such as measles, yellow fever, dengue, Zika, and chikungunya. These are my disclosures. When we look at recent outbreaks that we can find at the website of World Health Organization, you can see that since 2008 until now, most of them were caused by arboviruses or measles. Among the arboviruses, dengue is the most frequent infection, but we also had outbreaks of West Nile, chikungunya, Zika, and yellow fever. Most of these, we had several of them in Brazil and in the Americas. Concerning to the impact on transplant patients, you can see that excepted by Ebola, all of them had reports in transplant patients as a consequence of these epidemics. Concerning to dengue, dengue is by far the most frequent arbovirus infection, in 2019, Brazil was the leading of the number of cases. And in Brazil, Colombia, Mexico, and Guatemala, all the serotypes circulated during the epidemic. As by 2021, besides of Brazil, other countries had outbreaks of dengue. The same you can see concerning to chikungunya. In the year of 2022, chikungunya, they had a high circulation in 2017 and then decreased, but in 2022, we still have a lot of cases in the regions of America, more than 134,000 cases. Most of them, again, in Brazil, 133,000 only in Brazil. And Zika decreased significantly after 2017, but in 2022, we still have cases of Zika infection in the Americas, more than 12,000 cases, 11,000 in Brazil. And also, this is the historical series of yellow fever in my country from 1980 to 2018. And you can see that we had slight increase of number of cases every 8 to 10 years, up to 2016, when we had a sharp increase in yellow fever cases and a huge epidemic in the state of São Paulo and other states in the southeast region of Brazil. Concerning to measles, due to the decrease in the coverage rates of vaccination in most countries, measles has increased in several countries in the world. In 2019, more measles cases were reported in the world since 2006. More than 500,000 cases were confirmed in more than 108 countries as a consequence of these large outbreaks, and more than 140,000 patients die of measles in 2018. And here you can see also that there are clusters of, in several countries along the years. In Brazil, we had a huge outbreak in 2018 and lasting up to 2020 and had decreased recently. It's interesting to see that after the more than 20,000 cases in 2019, when started COVID pandemic, there a decrease in the number of measles. Of course, this is also maybe a consequence of low notification of the cases, but also the decrease of other, the respiratory virus infection as occurred with other respiratory virus as well. And now, what is the impact of these arboviruses and measles in transplantation? We have transmission-related threats, like for the arbovirus, for instance, many share the same vector. We have non-vector transmission also. We have diagnostic challenges because the clinical picture is maybe similar. And also we have cross-reactivity in serological tests that is difficult to diagnose. Some of these infections can be severe, like dengue, yellow fever, and measles. And also we have limitations to the use of the vaccines against measles, yellow fever, that they have vaccine to control, but there are live attenuated vaccines that are restricted in transplant populations. One concern of the non-vector transmission is the potential shortage of organs and blood. And there are several publications showing that for arbovirus, they can be transmitted not only by vector bite, but also by blood or by the graft. And as donors get infected, they can be the transplant. The donor can be deferred because of the donor is sick. Concern to the occurrence of they are transmitted by the same vector. What a possible consequence is the occurrence of multiple epidemics, such occurred in Brazil in 2017, when dengue, Zika, and chikungunya were circulating at the same time. You can see by the publications in this year, several cases of chikungunya and Zika in kidney and stem cell transplantation. These are the cases of Zika and chikungunya in stem cell transplant recipients, and also in oncohematological patients that we had the opportunity to detect during this triple epidemic that we had in 2017. 26 cases fulfilled the case definition criteria and were investigated for the dengue, Zika, and chikungunya. We had 9 proven arbovirus infection and 4 cases of Zika infection. While the Zika infections in stem cell transplant patients were mild and without complications, we had a severe case of dengue in the same population, in a 7-year-old girl. In hematological patients, we had the same observation. Zika cases were mild. The case that had delayed engraft, this patient had acquired Zika just before stem cell transplantation, and we observed a delayed engraftment, but of course, it's not possible to be certain that this Zika was the cause of the delayed engraftment. And as occurred in stem cell transplant patient, the dengue case was severe. Again, patient had a persistent leukopenia and had lost substantial loss of weight. Also, complication of dengue infection that we had observed during this period was the persistence of the infection. The duration of viremia in some patients lasted up to 80 days. So, and this, the consequence of this is not well understood, and we don't know what this can represent in terms of antigen stimulation and the impact on rejection or graft versus host disease. This is also our experience with measles in stem cell transplant patients. We had an outbreak many years ago, and 8 cases of measles were detected. All patients were susceptible to measles. And only susceptible patients acquired measles, and they respond to the infection with high avidity IgG antibodies, suggesting a secondary immune response. Another concern is about the severity of the disease and lethality rates. As I mentioned before, dengue, measles, and yellow fever can cause severe disease. And you can see that the rates of severe disease for dengue in transplant population in comparison to healthy population is much higher, and also the mortality rates. The same for measles, also with higher mortality rates. And in yellow fever, we had only, so far, only 1 case described in a kidney transplant recipient that occurred here in São Paulo, Brazil, when we had this massive outbreak 2 years ago. And in healthy population, most of the cases are asymptomatic or with mild symptoms, but when severe, the lethality is very high, around 40% or more than that. While dengue can be controlled by the control of mosquito, measles and yellow fever can be controlled by vaccination. But as I mentioned before, we have some restrictions and difficulties with the live attenuated vaccines. The restrictions are that these vaccines in stem cell transplant recipients can be used after the 2nd year in patients without immunosuppression or chronic GVHD. The response to these vaccines are less than in stem cell transplant patients, are lower responses in comparison to healthy subjects. But the adverse events for measles are very few and mild. In yellow fever, the adverse events are rare, but can be severe, and this justify the fear of vaccination by most stem cell transplant centers. The adverse events are more frequent after the first vaccination, and patients who had already been vaccinated rarely have a severe adverse event. We had the opportunity to observe the compliance to measles and yellow fever vaccination in our country. And this was a study that we conducted and submitted to publication in 273 patients. The compliance to measles vaccine was around 50%, and yellow fever only 21%. Have to realize that these patients have at least more than 2 years of transplantation and without immunosuppressive drugs or chronic GVH. The possible reasons for the low compliance may be the long time elapsed since transplantation, the fear of adverse events, and the lack of a dedicated team. We have the opportunity to observe that when we have a team dedicated to vaccination, in general, the program, the revaccination program is complete successfully. Concern to measles vaccine, the same series, we observed that allogeneic transplant recipients are more likely to be vaccinated than autologous transplantation. And then this is interesting because autologous maybe have less risk of complication of a live attenuated vaccine than the allogeneic ones. But also we observed that while more than around 60% of the allogeneic patients had received measles vaccine, only 30% of the autologous were vaccinated. However, this fear of adverse events seem not to be justified because these vaccines are safe and effective. We had the opportunity to vaccinate during an outbreak. We anticipated vaccination before the second year of transplantation. During an outbreak, as the patients were getting measles, we start to vaccinate the patients after the first year of transplantation, and even in some patients that were receiving immunosuppressive drugs. And this way we could stop the emergence of cases of measles during the outbreak. Concerning to yellow fever, there are reports of the use of the yellow fever vaccine safely, not only in solid organ transplantation, but also in stem cell transplantation. This report in kidney transplant, in solid organ transplantation, kidney, heart, and lung, and liver, sorry. These are reports of patients that were inadvertently vaccinated during an outbreak of yellow fever. They by themselves went to a vaccination center and got the vaccine. And despite the contraindication for vaccination, yellow fever vaccination, solid organ transplantation, these patients vaccinated and no complications. They had no complications. And the same was observed for measles, early measles vaccination, and also yellow fever vaccination in stem cell transplant patients. Another interesting data that I have we have several publications that show that is about the persistence of yellow fever antibodies in patients that had been vaccinated before the transplant. So, for instance, this series shows that first publication, 87% of the patients vaccinated before had antibodies after transplantation. The same report in Japan showed that the persistent for 22 months after transplantation. This other publication in Brazil, persistence of antibodies more than 3 years after transplantation. Another report from France, persistent in 70% at a median of 12 months after transplantation. And this other report from France also persistent of antibodies in 40% of the patients. So it's if there is this fear of the use of yellow fever vaccine, and a fear that seems justifiable because it's rare. Adverse events are very rare, but when they happen, they can be severe. So if you have the persistence of antibodies, why not vaccinated before the transplant, as the solid organ transplant recipients do? So what we have learned so far from these arbovirus and measles infections in transplant populations? Concerned to measles, we have to be aware that loss of previous immunity is progressive after transplantation, and they have to be revaccinated, as more than 60% of them are susceptible after 2 years. So it's important to vaccinate the patients. However, the presence of specific antibodies in high titers interfere on vaccine response. So, because it's a live attenuated vaccine. So it's important to check serology before vaccinating, not only to see if the vaccination is needed, but also if to predict the response to vaccination. Also, it's important to check periodically measles immunity after transplantation, because you can see that most of the cases of measles had been transplanted and had been vaccinated many years ago. So after 5-10 years of transplantation, they don't have antibodies against measles. So they have to be revaccinated periodically. And also, in case of an outbreak, if we need to anticipate the vaccination, this can be done safely with the measles vaccine. And concerned to yellow fever, immunity induced by vaccination may persist for years. So although the vaccine seems to be safe in transplant recipients, it's important to consider pre-transplant vaccinations in areas of yellow fever risk. And I thank you all for your attention.
Thank you, Clarissa, for that wonderful review and talk. Very educative indeed. We will, I again want to remind our participants to please post your questions. We will have time for questions and discussion after the next talk. It's my privilege now to introduce the speaker for the next talk, which is Dr. Genoveva Papanicolaou, who will speak to us on cytomegalovirus and varicella zoster virus infection. Dr. Papanicolaou is based at the Memorial Sloan Kettering Cancer Center at the Cornell University, New York, USA. Dr. Papanicolaou, the floor is yours. Thank you very much for being part of this program today.
Hello, everybody. Thank you for inviting me to speak today. I'm going to talk about CMV and VZV infections after stem cell transplantation. My name is Xenia Papanicolaou, and I'm an infectious disease attending at Memorial Sloan Kettering Cancer in New York. First, starting with CMV. CMV is a common and a very significant complication after transplant. It occurs in about 40% of allogeneic transplants and much higher in specific patient groups such as cord blood transplants. CMV disease is rare with the current strategies for prevention and ranges from 1 to 6% in low risk transplants and up to 10 to 20% in high risk patients such as haploidentical and T-cell depleted transplants. The most important impact of CMV is that CMV seropositive recipients have worse survival compared to CMV seronegative recipients, and CMV reactivation further increases this survival disadvantage. What are the risk factors for CMV infection? Well, there are patient and transplant characteristics that usually are the most important ones in the first 30 days. The most important risk for CMV reactivation is the seropositivity of the recipient. CMV seronegative recipients have a very low incidence of CMV infection. Other than that, the type of transplant, including the HLA match, with mismatch, it's a higher risk, including haploidentical transplants and cord blood transplants that are highly mismatched, the type of conditioning regimen, and any forms of T-cell depletion, such as fludarabine, alemtuzumab, ATG, and overall the intensity of the conditioning. So beyond 30 days, we start dealing with the complications of transplant, and graft versus host disease and delayed T-cell recovery are the main factors, risk factors for CMV reactivation. And after 100 days, again, it is the very late complications of transplant that result in delayed immune recovery. Also, CMV reactivation before transplant is a risk factor for reactivation after 100 days, as well as receipt of prophylaxis in the first 100 days. How do we diagnose CMV? Well, we start with a pre-transplant screening by checking CMV IgG to identify past infection or latent infection in the donors and the recipients. During and after transplant, we use PCR testing and potentially in some centers the CMV antigenemia assays to monitor for active infection. And third, we also have CMV-specific T-cell immunity assays that are currently not validated, but are used in certain settings to assess the ability of the host to respond to CMV. Now, let's talk about CMV infection and disease. CMV after primary infection establishes latency. So latency is the maintenance of intact viral genomes, but without any active replication. And latent infection is detected by a positive CMV IgG. And approximately 60 to 70% of adults in the US are seropositive and higher in other parts of the world. And seropositivity increases with age. After transplant, CMV may go into an active replication cycle. We call that active infection, and we detect it with a PCR. We find DNA in the serum or whole blood, and we call that CMV viremia or CMV DNAemia. And reactivation occurs in seropositive recipients, while primary infection may occur in recipients that are negative but receive a seropositive allograft. Now, the strategy of prophylaxis is to prevent active infection. If active infection occurs, we have preemptive therapy with the goal of preventing CMV disease. And of course, by preventing reactivation and preventing also disease, we hope to impact the non-relapse mortality. Now, there are pros and cons with each of these two strategies. Of course, with prophylaxis, we give a medication for chemoprophylaxis to all patients at risk. It can prevent direct and indirect CMV effects. If you have an effective agent, you may not need CMV monitoring, and it may impact all-cause mortality. However, a drawback are toxicities of the medications and cost, and perhaps also reactivation of CMV after stopping prophylaxis because of delaying immune reconstitution to CMV. Now, preemptive therapy is the therapy that we have been using for many years prior to the availability of letermovir, and preemptive therapy really has worked to prevent CMV disease. It targets the patients at higher risk, so remember it requires active CMV replication. It minimizes overtreatment, and it may improve CMV immune reconstitution because patients are exposed to CMV antigens. However, it may miss some cases of CMV disease that are not preceded by anemia or antigenemia. And we have active CMV replication, which occasionally, if the rate of replication is more rapid than the drug can deal with, may lead to development of resistance. And of course, with the current medications of ganciclovir, valganciclovir, foscarnet, we still have a lot of toxicities. Moving into the medications, for many years, we have the 4 top medications that target CMV polymerase. Ganciclovir and valganciclovir is the most commonly used one, particularly valganciclovir because it's available orally, and they are recommended for first-line preemptive therapy. The major toxicity is myelosuppression and particularly neutropenia. That is dose-dependent and becomes more frequent as you use longer duration. Foscarnet is recommended for ganciclovir resistance or intolerance, and foscarnet is given intravenously, is highly nephrotoxic, requires very intense electrolyte monitoring, and results frequently also in fluid overload due to the requirements for hydration. We are very excited to have in the last 5 years, not 1, but 2 new medications that really meet some unmet needs. Here is a schematic part of the mechanism of action, and the 3 established medications, ganciclovir, foscarnet, cidofovir, target the DNA polymerase. We have 2 new medications that have mechanisms of actions that are specific to CMV, starting with letermovir. Letermovir targets the UL56 gene and inhibits the CMV terminase complex. Is the enzyme, the group of enzymes that cleave the viral DNA into the appropriate size virions to be packaged into the capsids. And it is approved for prevention of CMV in seropositive patients in the first 100 days after transplant. Maribavir is a medication that inhibits the UL97 gene, and it has multiple mechanisms of action. It inhibits replication and capsidation and the exit of the virions from the nucleus into the cytoplasm. It's currently approved only for treatment of resistant or refractory CMV in stem cell and solid organ transplants for patients 12 years or older. And it is being evaluated as first-line preemptive therapy, and the trial has been completed, and we are waiting for results against ganciclovir. I will briefly talk about letermovir because it has been very instrumental in our practice. Letermovir was evaluated in a large phase 3 trial compared to placebo to prevent CMV infections or CMV viremia. When given the first 14 weeks post-transplant. And the primary endpoint was on week 24. And as you can see, letermovir was very effective in preventing CMV viremia while it was given up to week 14. And while after week 14, we had some CMV viremia, as you can see, 18.9% by week 24, it was still much lower than the placebo. Importantly, letermovir was very safe, did not have myelosuppression, no nephrotoxicity. The side effect profile was similar to the placebo. A very important aspect of the trial was the demonstration of an impact on overall survival. And as you can see, there is a 5-point mortality difference at week 24, which was significant, and persistent of this survival advantage up to week 48, which of course has lost significance because the sample size was smaller. So we have implemented letermovir in our practice for all patients, and we have seen dramatic decreases in our use of antivirals, and we even continue letermovir beyond 100 days in patients who are remain at high risk, such as those that have graft-versus-host disease and require corticosteroids or T-cell depleted transplants. And currently, a phase 3 study has been completed to evaluate really a longer prophylaxis up to 200 days for these types of patients, and we are waiting for results. Now, what happens if prophylaxis or preemptive therapy goes wrong and we develop, we have refractory or resistant CMV infection? And you can see the consensus definitions that we have come up with. In clinical practice, refractory CMV is an infection that does not improve after 2 weeks of appropriately dosed antivirals. And resistant CMV is being refractory, so lack of clinical response plus the presence of resistance mutations. What are risk factors for resistance? Profound immune suppression and suboptimal doses of antivirals. Sometimes we tend to reduce or interrupt treatment because of toxicities or poor compliance or poor absorption of oral medications. Resistance is rare in matched-related transplants without GVHD, but more common in patients that receive manipulated or highly mismatched grafts. And here is the constantly increasing number of mutations that confer resistance, and the number is being constantly increasing as we get more drugs, and we also learn more about mutations in the drugs we know. Now, it's important to know the resistance mutation to guide therapy. The general rule is that if a patient has been exposed to ganciclovir, valganciclovir alone, foscarnet works, and vice versa. It becomes more complicated if patients have received sequential treatments with multiple classes of drugs, where you can have double or triple mutants. Maribavir, in general, resistance does not have cross-resistance with the other 3 drugs, with the exception of one mutation. And letermovir really doesn't really have cross-resistance with the other antivirals. What do we have for resistant CMV? I talked about maribavir, and just to give you the top line results, this is the results of a clinical trial where maribavir was evaluated against investigator-assigned therapy. So what was the institutional standard of care for refractory or resistant CMV? And you can see that maribavir performed better in clearing viremia by 8 weeks without any safety concerns. And now it is available in the United States. These are our guidelines, the ASTCT guidelines for managing resistant refractory CMV. I highly recommend to consult them if you have a case. And these guidelines were before maribavir, but now for transplants, we would recommend maribavir as first line for refractory CMV, with exception of situations that there is concern for CNS involvement. So if there are concerns about encephalitis, retinitis, maribavir does not penetrate the CNS and should not be used. Also, maribavir and letermovir do not have activity against herpes simplex and VZV, and so you need to use acyclovir when you are using these drugs. Key points: just review transplant and patient characteristics to identify patients at risk for reactivation. Routine surveillance at least through day 100, and then as indicated by risk. Prophylaxis and preemptive strategies are complementary and not mutually exclusive. Every center should have both strategies in place. Request genotype when you expect resistant refractory CMV, and consider these 2 new drugs for the appropriate indications. Moving to varicella zoster virus. When we talk about VZV in transplants, we talk about reactivation, and we call it herpes zoster. Without prophylaxis, it occurs in 20 to 50% of patients, and it is noted to have increased disease severity and complications compared to the general population. Its incidence is as high as 18% in allogeneic and 90% in autologous transplants, an incidence rate of more than 40 per 1,000 patient years. This is at least 3 times higher than the general population or even special groups as solid organs or HIV patients. Complications are also more frequent after transplant, post-herpetic neuralgia, severe ocular or otic complications, and life-threatening complications such as encephalitis and disseminated disease may occur, although rarely. Prophylaxis is the cornerstone of management. It's been effective and it's shown efficacy in randomized trials and real-world studies. We recommend prophylaxis for at least 12 months, but duration varies among different centers. Acyclovir 400 milligrams twice a day is sufficient. Some centers use higher doses of valacyclovir 500 milligrams PO BID. We start prophylaxis at the time of admission for transplant, and as said, continue at least for 1 year. We continue for up to 36 months in high-risk patients, and of course, until much later than vaccination. Goals of treatment, if we have a herpes zoster, is to lessen severity and duration of pain associated with the acute phase, the acute neuritis, promote rapid healing of lesions, prevent new lesions, and decrease viral shedding to reduce transmission. The key, as with many viruses, is to start treatment early. Typically, we will say less than 72 hours from the onset of rash. However, in our population, we give treatment even after 72 hours if new lesions are appearing at the time of presentation. For uncomplicated treatment, we can use oral valacyclovir 1 gram every 8 hours, or famciclovir or acyclovir, which we don't recommend because it is a very high dose and requires 5 times a day dosing, which may be a problem with compliance, and we continue until all lesions are crusted. For severe zoster, meaning more than 1 dermatome, or any zoster in the face, we use acyclovir IV, and we don't use Varizig. It's difficult to obtain it. It would be only indicated for cases of pneumonitis or perhaps very severe disseminated disease. Take care of superinfected skin lesions and prescribe antibiotics, but only as needed. And acyclovir at high doses has the potential of renal toxicity, so be sure to adjust for creatinine clearance and maintain adequate hydration. Acyclovir resistance, it is rare to my experience, but it may happen. Unfortunately, we only have available phenotypic resistance that take time, so the results will not be available in time to make clinical decisions, but it's something to consider in severe cases of herpes zoster that occur while the patient is taking appropriate prophylaxis. Prevention of zoster, we have 3 available vaccines. 2 of them are live, and currently we don't use them anymore. The most recent one is the recombinant shingles vaccine called Shingrix, and has really replaced the live vaccines. And I'm going to talk briefly about the data that brought this change. So the recombinant zoster vaccine was evaluated in autologous stem cell transplants. And as you can see from the graph on the left, it reduced the incidence of herpes zoster with an adjusted hazard ratio of 0.3, and also had some impact on the post-herpetic neuralgia. So definitely a positive study. Importantly, the first dose was actually given 60 days after transplant, as early as 2 months after transplant, and the second dose about 2 months later. Now, of course, in this study, many patients continued acyclovir. The idea was to, the trial was designed to have acyclovir for 6 months, but many centers had elected to use it for 12 months, but still a positive trial. And a smaller trial, a smaller study, retrospective one for allogeneic transplants, because we did not have any guidance in allo transplants, where again we show that the safety was of the Shingrix vaccine was comparable to other immunocompromised populations. Reactogenicity, this vaccine has pain and swelling at the injection site, so reactogenicity occurred similar to other populations. Chronic GVHD, always a concern if you give vaccinations to allo transplants, no difference than historical controls, and the breakthrough infection was low, 2.5%. So a small retrospective study, but with encouraging results. And my last slide is missing, but it was to say our current practice. So now Shingrix has replaced both live vaccines. We give Shingrix as early as 2 months after auto transplants, and we start the allos. We give it at 1 year. Providing, of course, that they are suitable to receive vaccinations with all the other caveats of lack of GVHD, corticosteroids, etc. While other centers really do give Shingrix to allos at 6 months. I will stop here, and I will be happy to take questions in the end. Thank you for listening.
Thanks very much, Clarice, Simone, and Xenia. Thanks very much for your wonderful lectures. We have 10 minutes for the Q&A session. There are many questions here, but let's start with Simone with the first question. In patients who have multiple viral reactivations, here is the case of a patient with concomitant BK virus hemorrhagic cystitis and CMV viremia. What would be your choice in terms of therapeutic options? Here it is mentioned cidofovir, ganciclovir. What would be new for the future also?
Okay, I think that it is very personalized on the patient decision. But if I am in a situation where the viral load for CMV is increasing, the first choice is ganciclovir. If I have a reactivation stabilized as a viral load or decreasing, on the other end, the first choice should be Cidofovir that also give me a covering for CMV. So it depends on the dynamics of a CMV viral load. If we are in the increasing phase, the first choice for me is ganciclovir. If not, I can switch to Cidofovir.
Thank you. Maybe I'll go for a question for Clarisse. Thank you for the nice talk. These are relatively less common within the hematopoietic stem cell transplant. These infections, measles, yellow fever, dengue, Zika, and chikungunya. What data do we have on mortality to justify screening and vaccination?
Well, concerning to
any
measles,
of these, because we are, the measles is the one where we're doing regular vaccination. The others we are not in many parts of the world. So how much data do we have on significant morbidity or mortality? These are less common reports.
I think the recommendation for places or countries that you don't have a high prevalence rate is not to vaccinate. The recommendation is if you travel to regions where the disease can occur or are occurring, for instance, during epidemics. This is clear for yellow fever. But for instance, if one can travel to Brazil, they are recommended to get a yellow fever vaccine. So if he's a recipient of a transplant, solid organ or stem cell, they have to, the physician has to consider or change your destination or check if the patient the vaccination is safe. In the case of solid organ transplantation, is contraindication. Absolute contraindication after the transplant. What I suggest for regions that have a high incidence of yellow fever, for instance, Brazil, all over the country, the vaccine is recommended. So if you fear the adverse events, why don't we vaccinate the patients before? That's what happened with the solid organ transplantation here in Brazil.
Thank you.
Concerning to measles, we also have, not only in Brazil, but all over the world, you not only vaccinate to protect the patient, but to give the patient the same protective levels that the whole community have. And it is a public health attitude. So it's recommended to vaccinate it for the patient has the same profile as the other person in the community. And there are reports of 50% mortality of measles in some series. So this is the evidence that can be severe. The best is to check serology for see if the patient need to be vaccinated. And in our experience that we have vaccinated a lot, and even in the first year of transplantation, the measles vaccine is safe. And
Thank you, Clarisse. We will keep the answers short because we have more questions to go through. Thank you. Sebastian, you want to go to the next one?
Thanks, Clarisse. Let's go to Xenia because there are many questions regarding CMV prophylaxis, mainly because accessibility to letermovir is very limited in most of the regions of the world. And one question is, can you comment on, for example, using other antiviral drugs such as acyclovir? Or one question also is on low-dose valganciclovir for CMV primary prophylaxis after transplant. What can you tell us about this?
Right. So ganciclovir works for prophylaxis when you give it, and there are trials to show that it works. The problem is with valganciclovir or ganciclovir, whichever you give at the maintenance dose, is that it is myelosuppressive. So you will have to deal with that, and giving valganciclovir or ganciclovir for 100 days is a lot. Now, in certain circumstances, and so that is the difference also from solid organs. The solid organs do not have such a vulnerable marrow. In stem cell transplants, the marrow is the most vulnerable organ. So in cases that you need it, absolutely need it, yes, but in cases that you can treat preemptively, standard risk patients, if you have a sensitive method and you monitor routinely and consistently, you start treatment early, preemptive therapy will work. Extreme situations, patients who had CMV pre-transplant, extreme difficult grafts, then ganciclovir prophylaxis may be considered, but many patients cannot get it because they have to stop because of myelosuppression.
Thank you. We will go for a question for Simone now. So the question here is, do you routinely monitor for EBV in sibling transplant? And I will add to that, with or without GVHD, and or only for alternative donor transplants such as haplo or MUT?
Yeah, certainly, I monitor the unrelated donor transplant, haplo transplant. For sibling transplant, if, for example, I have conditioned the patient with the ATG, for example, for sibling transplant in severe aplastic anemia, certainly I perform the EBV monitoring. Otherwise, you can hope to not to do this. I do in my practice. I do this because it's a very practical. Because of the sibling transplant are 15%. And all the volume of a transplant, so it is more difficult to say one patient yes, one patient no. So it's more easier to give a simple order for all the equipe in order to not in order to maintain a good standard of monitoring. But it depends on if I use a GVH ATG or not in the conditioning regimen. The most driving key indicator for EBV monitoring or not.
Okay, I'm not sure we're going to be able to come back to you, Simone. So one quick short question and a short answer. In countries where there is no cidofovir, for BK virus HC, is management only supported?
Yeah, unfortunately, this is the situation, but also in Italy, we have not cidofovir so far. Perhaps it will be introduced next month, because now cidofovir is imported, but is authorized only for the classical indication of CMV retinitis, CMV refractory disease. So the most important supportive care so far.
Well, yeah, just the last question for Clarice and also for Xenia. Do you monitor, and also a short answer, and then Alok will close. Do you monitor similarly HLA identical siblings than, for example, haploidentical transplant? More or less the same question that we asked Simone. Routinely.
A little bit different in the high-risk patients. I think CMV is mostly the same, with the exception that the haplos and T-cell depleted are monitored for much longer. And of course, haplos and TCT are monitored also for EBV, and also we do for adenovirus.
Clarice? You are muted, Clarice.
We monitor CMV for all the allogeneic, and depending on the risk, we prolong if they have prolonged the immunosuppression, they prolong the monitoring as well. And in some centers, we monitor also HHV6, but not all the centers. And EBV for the unrelated and haplos. And BK not monitored, not only diagnosis.
Sebastian, we were maybe 2 or 3 minutes late in starting. So there are 2 questions in Spanish, I think. Do you want to?
Yeah, I have just, I mentioned
You've done it already?
Yeah, no
okay.
problem.
Good. Okay,
you can close.
Okay, so there's a last question from Adriana about the problem of the new adenovirus and monkeypox. Do we know if there are threats for stem cell transplant patients? Who wants to take that? Short, quick.
I will pass that to Clarice. I mean, of course, we are vigilant about that. It remains to be seen, right?
Yeah. I think that's a fair answer. Okay, so we've come to the close of this wonderful session. I want to thank all the speakers first and all the participants. I don't know how many countries, but we certainly had more than 120 people online for this session at the moment. So thank you all very much. I also want to thank Sebastian and the WBMT for this collaboration. And finally, MICE Ideas for supporting this program without any cost to the two societies. Thank you so much.
Thank you.
Bye-bye.
Bye.